Done, madam.
Yes. Namaskara ellarigo. Good evening, one and all. Well, it's my proud privilege to touch two very hot topics of the month. That one is the membership drive. The other thing is the free vaccination drive for 14-year-old girls. To get more information on that, we have stalwart Dr. Deepak with us. And before we start, I request Dr. Indra to say Dr. Raju to say the IMA prayers.
Good evening, everybody. Indian Medical Association prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the dealing cure beyond every greed and lure. Coming to flag salutation, we, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Thank you.
Jai Hind, IMA Chirayuvagirali. Now I request our President, Dr. Veerbhadraya sir, to say a few words.
ಎಲ್ರಿಗೂ ನಮಸ್ಕಾರ. ಈ ದಿನ ಮೆಂಬರ್ಶಿಪ್ ಡ್ರೈವ್ ಕಮಿಟಿಯಿಂದ ಮೆಂಬರ್ಶಿಪ್ ಡ್ರೈವ್ ಬಗ್ಗೆ ಮಾತನಾಡಕ್ಕೆ ಡಾಕ್ಟರ್ ಅನುರಾಧ್ ಅವರು ಇದ್ದಾರೆ. ಎಲ್ಲರೂ ಈಗ ನಮಗೆ ಕನ್ಸೆಷನ್ ರೇಟ್ ಇರೋದ್ರಿಂದ ಹೆಚ್ಚಿನ ಸಂಖ್ಯೆಯಲ್ಲಿ ಸದಸ್ಯರಾಗಬೇಕು, ಸದಸ್ಯತ್ವನ ಪಡಿಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ನಾನು ಸಹ ಮನವಿ ಮಾಡ್ತೇನೆ. ಅದೇ ನಿಟ್ಟಿನಲ್ಲಿ HPV ವ್ಯಾಕ್ಸಿನೇಷನ್ ತಮಗೆಲ್ಲ ಗೊತ್ತಿರೋ ಹಾಗೆ ಈ ಫ್ರೀ ವ್ಯಾಕ್ಸಿನೇಷನ್ ಶುರು ಮಾಡಿದ್ಮೇಲೆ 1,20,000 ದಾಟಿದ್ದೇವೆ ಈಗ ನಾವು ನಮ್ಮ ರಾಜ್ಯದಲ್ಲಿ. ಇನ್ನು ಈ ಒಂದು ಡ್ರೈವ್ ನಡೀತಾ ಇದೆ ಎಲ್ಲ ಕಡೆ, ಎಲ್ಲ ಜಿಲ್ಲೆಗಳಲ್ಲಿ. ಸೊ ಇನ್ನು ಹೆಚ್ಚಿನದಾಗಿ ಸಾಧನೆ ಮಾಡೋ ಸಾಧ್ಯತೆಗಳಿವೆ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ನಾವು ಸಹ ಹೆಮ್ಮೆಯಿಂದ ಕೈ ಜೋಡಿಸ್ಬೇಕು. ಮತ್ತೆ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಹೆಚ್ಚಿನ ಹೆಣ್ಮಕ್ಳು ಭಾಗವಹಿಸಾಗ ನೋಡಿಕೊಂಡು ಅವ್ರಿಗೆ CS ಸರ್ವಿಸ್ ಪ್ರಿವೆನ್ಷನ್ಗೆ ನಾವು ಅಡಿಪಾಯ ಹಾಕ್ಕೊಡ್ಬೇಕು ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಕೇಳ್ಕೊಳ್ತಾ ಈ ಒಂದು CME ಯಶಸ್ವಿಯಾಗಿ ಜರುಗಲಿ ಅಂತ ಹಾರೈಸಿ ನಾನು 2 ಮಾತು ಮುಗಿಸ್ತೇನೆ. ಧನ್ಯವಾದಗಳು.
ವಂದನೆಗಳು ಸರ್. I request Dr. Suriraju, our secretary, to say a few words.
Good evening, everyone. Today, membership drive committee under the leadership of Dr. Anuradha Madam is organizing wonderful topics today. One is HPV vaccination, where we are today, because government, as we are all aware, national government has is giving free vaccination for all. On that, I welcome Dr. Deepak KG, State Technical Manager, HPVVPA Project, JSI India. It is a golden opportunity. Why? Because as we are aware, cancer cervix stands highest in the entire world in India. So by giving HPV vaccination, 98% of the cancers cervix can be prevented. So it is our duty, Indian Medical Association, joining hands with the state as well as national government, can eradicate completely, control CS cervix. So I want to congratulate IMA Karnataka State Branch under Dr. Anuradha Madam, because they have done a wonderful job. Vaccinating 30,000 people is not easy job, and we are able to create awareness and vaccinate many people. I think every one of us should join hands and create awareness about HPV vaccination ಅಂತ ಹೇಳ್ತಾ. At the same time, I want each and every member, to motivate your friends to actively participate and take membership drive. And just another 10 days is there, as National IMA headquarters has given 25% discount. This is a golden opportunity. Many people keep asking why IMA. Lot of advantages, and it is our duty to create awareness and advantages of IMA to all the doctors and strengthen Indian Medical Association. Once again, thank you for giving me this opportunity. Thank you, madam.
Thank you, sir. I request our President-elect, Dr. Harish, to say a few words.
Thank you, madam, for giving me opportunity to
Thank you, sir.
speak. And you are doing excellent job. And I totally endorse the words of our beloved President, sir, and as well the Honorary Secretary. And I wish the function a success. Thank you.
Thank you, sir. So now we move on to the first topic, that is IMA membership drive. I wouldn't intrude into Dr. Deepak's time because we have lots to know about what government is doing and what the government target is. So with a target of 5.3 lakh girls aged 14 years in Karnataka, the coverage so far has been only 1.46 lakhs. And in BBMP, the Greater Bangalore, the expectation coverage is not, it's just 5 to 6%. So we have got a lot of responsibility in terms of motivating our BBMP doctors to see to it that their 14-year-old girls take the vaccination and make sure that so far about 1.5 lakh HPV Gardasil vaccine doses have already been utilized by our 14-year-old girls. Another 3.5 lakhs is there in the cold storage, and we have to see to it that before this 3 months is over, all those 3.5 lakh doses are completely exhausted, because we have our target coverage is 5.3 lakh girls in Karnataka. This is the statistics that has been tabulated pan India, and for Karnataka the statistics says this. So before I move on to our membership drive, I thought I will make sure that we are fully charged and motivated to see to it that we don't waste even a single dose of the vaccine, that the expensive quadrivalent Gardasil vaccine that is being provided free of cost to all our girls. So, and every day the vaccine is being given in all our health centers after they are registering in UWIN portal. Exact from the horse's mouth, ಶಂಖದಿಂದನೇ ತೀರ್ಥ. ಅದರಿಂದ ನಮ್ಮ ದೀಪಕ್ ಸರ್ ಅವರು ನೀಟಾಗಿ ನಿಧಾನಕ್ಕೆಲ್ಲ ಹೇಳ್ತಾರೆ. ನಾನು ಮೆಂಬರ್ಶಿಪ್ ಡ್ರೈವ್ ಬಗ್ಗೆ ಈ ತಿಂಗಳು ನಮ್ಮೆಲ್ಲರೂ ತಿಳಿದಿರೋ ಹಾಗೆ ಈ 30ನೇ ತಾರೀಕುವರೆಗೂ ನಮಗೆ 25% ಡಿಸ್ಕೌಂಟ್ ನ್ಯಾಷನಲ್ ಹೆಡ್ ಕ್ವಾರ್ಟರ್ಸ್ ನವರು ಕೊಟ್ಟಿದ್ದಾರೆ, ನಮ್ಮ ಸ್ಟೇಟ್ ನವರು ಕೊಟ್ಟಿದ್ದಾರೆ, ನಮ್ಮ ಬ್ರಾಂಚ್ ಲೆವೆಲ್ ಅಲ್ಲೂ ಕೂಡ ನಮಗೂ ಹೇಳಿದ್ದಾರೆ ನೀವು ಕೂಡ ಡಿಸ್ಕೌಂಟ್ ಕೊಡಿ ಅಂತ ಹೇಳಿ. ಸೊ ಆಕ್ಚುಲ್ ಆಗಿ ಈ ಒಂದು ಡಿಸ್ಕೌಂಟೆಡ್ ಆಫರ್ ನನ್ನ ಪ್ರಕಾರ ಸಿಂಗಲ್ ಮೆಂಬರ್ಶಿಪ್ಗೆ 10,000, ಮತ್ತೆ ಕಪಲ್ ಮೆಂಬರ್ಶಿಪ್ಗೆ 15,000, ಮತ್ತೆ ಹಾಫ್ ಕಪಲ್ಗೆ 5,000. ಇಷ್ಟು ಕಡಿಮೆ ಪ್ರಮಾಣದಲ್ಲಿ ನಮಗೆ ಮುಂದೆ ಎಂದೆಂದೂ ಕೂಡ ಇಷ್ಟು ಕಡಿಮೆ ಡಿಸ್ಕೌಂಟ್ ಅಲ್ಲಿ ಖಂಡಿತ ನಮ್ಗೆ ಲೈಫ್ ಮೆಂಬರ್ಶಿಪ್ ಸಿಗೋದಕ್ಕೆ ಖಂಡಿತ ಸಾಧ್ಯವಾಗಿ ಆಗಲ್ಲ. ಈಗ ನಮ್ಮ ಹೆಡ್ ಕ್ವಾರ್ಟರ್ಸ್ ಅಲ್ಲಿ ಸಾಕಷ್ಟು ಜನ ಪ್ರಶ್ನೆ ಕೇಳ್ತಾರೆ, ಬಿಲ್ಡಿಂಗ್ ಫಂಡ್ ಅಂತ ಕೇಳ್ತಾ ಇದ್ದೀರಲ್ಲ, ನಮ್ಮ ಇದು IMA ಹೌಸ್ ಬೆಂಗಳೂರಿನಲ್ಲಿ ಪೇಂಟಿಂಗು ರೆನೋವೇಷನ್ ಎಲ್ಲ ನಡೀತಾ ಇದೆಯಲ್ಲ, ಅದಕ್ಕೋಸ್ಕರ ದುಡ್ಡು ಕಲೆಕ್ಟ್ ಮಾಡ್ತಿದ್ದೀರಾ ಅಂತ ಇವತ್ತು ಸಾಯಂಕಾಲ ಒಂದು MSN ಸ್ಟೂಡೆಂಟ್ ಕೇಳ್ದ. ಅದಕ್ಕೆ ಅವ್ನು ಹೇಳ್ದೆ, ಇಲ್ಲಪ್ಪ ಬೆಂಗಳೂರಿನವ್ರಿಗಲ್ಲ, ಅದು ಹೆಡ್ ಕ್ವಾರ್ಟರ್ಸ್ ಅಲ್ಲಿ ಹಳೆ ಬಿಲ್ಡಿಂಗ್ ನ ಕಂಪ್ಲೀಟ್ ಆಗಿ ಡೆಮಾಲಿಷ್ ಮಾಡಿ ಹೊಸ ಬಿಲ್ಡಿಂಗ್ ಕಟ್ತಾ ಇದ್ದಾರೆ, ಆ ಬಿಲ್ಡಿಂಗ್ ಗೋಸ್ಕರ ಅಂತ. 1,000 ರೂಪಾಯಿ ಮಿನಿಮಮ್ ಅಷ್ಟೇ ಅಂತ ಹೇಳಿದ್ರೆ ಅವನು 2,000 ರೂಪಾಯಿನ ಇದ್ ಮಾಡಿ ಸ್ಕ್ಯಾನ್ ಮಾಡಿ ಕಳ್ಸಿಕೊಟ್ಟಿದ್ದಾನೆ. ಸೊ ಈಚ್ ಅಂಡ್ ಎವ್ರಿ ಒನ್ ಆಫ್ ಅಸ್ ಡಾಕ್ಟರ್ಸ್, ಇನ್ ಅಡಿಷನ್ ಟು ಬೀಯಿಂಗ್ ಕಮಿಟೆಡ್ ಟು IMA for taking help from IMA, we also need to show our commitment in terms of our integrity. That integrity can happen only when we increase the numbers. So ನನ್ನ ಕನಸು ಏನು ಅಂದ್ರೆ, ಈ ಕಡೆ ತಿರುಗಿ ಈ ಡಾಕ್ಟರ್ ನೋಡಿದ್ರು ಕೂಡ ಅವರು IMA ಮೆಂಬರ್ ಇರ್ಬೇಕು, ಹಿಂದೆ ನೋಡಿದ್ರೆ ಅವರು IMA ಇರ್ಬೇಕು, ಮುಂದೆ ಇರೋರು ಕೂಡ IMA ಮೆಂಬರ್ ಇರ್ಬೇಕು. ಯಾವೊಂದು ಡಾಕ್ಟರ್ಗೂ ಕೂಡ ಯಾವ ರೀತಿನೂ ಕೂಡ ಎಲ್ಲೂ ತೊಂದರೆ ಆಗ್ಬಾರ್ದು, ವೈಲೆನ್ಸ್ ಅನ್ನೋ ಪದನೇ ನಮ್ಮಲ್ಲಿ ಇರಬಾರ್ದು. ಆ ರೀತಿ ಒಂದು ಅಟ್ಮಾಸ್ಫಿಯರ್ ಕ್ರಿಯೇಟ್ ಮಾಡೋದಕ್ಕೆ ನನ್ನ ಪ್ರಕಾರ ಮೆಂಬರ್ಶಿಪ್ ಅಲ್ಲಿ ನಂಬರ್ಸ್ ಇನ್ಕ್ರೀಸ್ ಮಾಡೋದು ಮಾತ್ರ ಅಲ್ಲ, ಮೆಂಬರ್ಶಿಪ್ ಜೊತೆಗೆ ನಮ್ಮ ಅಕಾಡೆಮಿಕ್ ಅಪ್ಡೇಟು ಮಾಡೋದು. ನಾನು ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡುವಾಗ ನನ್ನ ಪೇಷಂಟ್ಸ್ ನ ಸರಿಯಾಗಿ ನೋಡ್ಕೊಳಕ್ ಬರೋದೇ ಹೋದ್ರೆ, ಅಥವಾ ಪೇಷಂಟ್ಸ್ ಹತ್ರ ಸರಿಯಾಗಿ ಮಾತಾಡ ಆಗದೆ ಹೋದ್ರೆ, ಅಥವಾ ಪೇಷಂಟ್ ಹತ್ರ ಮಾತಾಡುವಾಗ ಇವ್ರು ಏನೋ ನನ್ಗೆ ಈ ರೋಗಿ ಯಾಕೋ ನನ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಸಮಾಧಾನ ಇಲ್ಲ, ನಾಳೆ ಲಿಟಿಗೇಷನ್ ಹೋಗ್ಬೋದು ಅಂತ ಅನ್ಸ್ದಾಗ, ಅವಾಗ ನಾನು ನನ್ನ ಸ್ನೇಹಿತರ ಸಹಾಯನ ಪಡೆದು ನಾನು ಒಂದು ಯಶಸ್ವಿಯಾಗಿ ಡಾಕ್ಟರ್ ಆಗ್ಬೇಕು. ನಾನು ಅಂದ್ರೆ I mean each and every doctor. So I request each and every one of you to make sure that you don't find any non-IMA doctor amongst us. But IMA is very, very generous. Even though you are not IMA member, you can still participate in all the IMA webinars and CMEs. But make sure that we do it, because let us protect our family through social security scheme. Let us protect ourselves and have a very tension-free practice with KPPS membership enrollment. And last but not the least, namdu health insurance kuda 2 lakhadvargu coverage ide. Over and above the medical insurance that we claim, we have this extra benefit not only for yourself but also for your dependents. And these dependents, all of us can avail this health insurance up to the age of 85 years without any health checkup when we enroll. So the last date for this IMA membership is 30th April. And here is the scanner. All that you and me have to do is just scan. I'm speaking about those doctors who want to become IMA members. Just scan this and pay the amount. I am a doctor, but my spouse is not a doctor. So mine will be single membership. So I pay 10,000 rupees for IMA Karnataka State Branch. This scanner, the money goes to the Karnataka State Branch. Apart from this, we individual branches, we have our own scanners, another scanner. In that scanner, we will ask our members to deposit, say 1,000, 2,000, 2,500. Each one of us, we decide amongst ourselves in our branch. The branch committee members take a decision along with the president and secretary as to how much the branch fee has to be done. So there will be 2 scanners for us. The first scanner is for the Karnataka State Branch. The second scanner is for the respective branch. So what you need to do is first finish off scanning so that money is deposited to the respective branch. And after that, we can fill up the application form. John, next slide. Yeah, this is the scanner, and these are the webs. Next, this is the scanner that we use to deposit the money, and these are the addresses of the various websites. So Pan India, the first one is the IMA website. Second one is the Karnataka State Branch website. The third one is the Social Security Scheme website. The fourth one is the Health Scheme website, and the last one is the Professional Indemnity Karnataka Professional Protection Scheme, this thing, scanner, a website. And the last one, I belong to IMA Bangalore branch. So I have just displayed the IMA Bangalore branch website also. So for Bangalore branch members also, they can directly scan paying 10,000, and subsequently the branch fee we pay, it is 2,450 for Bangalore branch members. And the documents that we need, John, next slide, that we need to attach this hard copy, we need to send it to Ravi Kiran at IMA Karnataka State Branch office on first floor. And we can send it by, we have now the, port. We have a very easy way of sending the hard copies. No need to wait for courier at all. So the first one is the filled in application form. Make sure that you have signed on the application form, because this signature will be valid throughout our membership. And proposed by, don't forget to mention the name of the doctor who has suggested this membership opportunity to you. And if you know his or her membership, you can add to that. Otherwise, the respective branch secretary will check and do the entry. Then you need your photo also, passport size photo, degree certificate, Karnataka Medical Council certificate. Mandatory is the KMC certificate. Then Aadhaar copy, that is to get the correct spelling of your name as well as your address and contact details. Next slide, John. Yeah. So apart from the 25% discount opportunity that we have for the Alive membership, which ends on 30th April, we also need to heed to the requirement of the building fund. So we have a scanner for this, and we request each and every member to just deposit 1,000 rupees. So for example, in Karnataka State Branch, we are 31,000 plus members. So each one of us deposit, it comes to 30 lakhs. Of course, we have already crossed that 30 lakh target. And yes, next slide, Bijan. Yes, earlier, kindly note the single membership for Karnataka State Branch was 15,000. Now it is 10,000. Couple membership earlier was 22,000. Now it has been brought down to 15,000. And half couple earlier we used to pay 9,000 rupees. Now the half couple membership is 5,000. What is the meaning of this half couple is, when I became a member, I was not married. So I took up the single life membership. But tomorrow when I get married, if my spouse is a doctor and if my spouse is not yet IMA member, so he will utilize the same IMA membership number and pay just 5,000 and join me. So both of us will have a common membership number, but we will be filling up the individual application forms. And this is the way we are going to deposit the money. So we call all doctors to join IMA. Make sure that you pay the scan and do the payment before 30th. In a 1 or 2 day delay in submitting the hard copies is quite okay, but payment has to complete, because after 30th we don't get the discounted membership fee. Next slide, John. Yeah, let's get all our allopathy doctors under the umbrella of IMA. Jai Hind, long live IMA. Thank you one and all for a patient hearing. So now I request Dr. Indra to introduce our esteemed speaker, Dr. Deepak.
Madam, before concluding, one small announcement.
Yes, sir.
Actually, for the efforts you have done to, paste a banner for the membership drive, I have to thank Dr. Veerbhadra sir because of his efforts, and Dr. Yoganand Reddy sir. Right now, the banner is, installed today. I want to
excellent.
congratulate you. So
Yes, sir.
John will share that. This is today one of my friend who went for KMC registration just took a photo and he sent me. That's why I wanted to share with good news. Thanks to Dr. Veerbhadra sir, President sir. Yes.
Actually, it
Yes,
was
sir.
decided on Saturday.
Yes, sir.
All 3 days for holidays.
Holidays. Yes, sir. So sincere thanks to our President, Dr. Veerbhadra sir, for giving us an appointment to meet the committee and also celebrate your birthday. And we had a sumptuous lunch as well as cake cutting. And definitely he moved forward to make sure that all our KMC members get the information about membership. And also he has been very, very, very generous in we sent mail from IMA to KMC and got the approval from the committee. And again, a very sincere thanks to our president for the excellent backup that you have been giving. Thank you. Dr. Indra.
Namaste ಎಲ್ಲರಿಗೂ. I am Dr. Indra from Doddaballapur. Today, madam ನನಗೆ ತುಂಬಾ ದೊಡ್ಡ ಜವಾಬ್ದಾರಿಯನ್ನ ಕೊಟ್ಟಿದ್ದಾರೆ. ಆ ಜವಾಬ್ದಾರಿ ಏನಪ್ಪಾ ಅಂದ್ರೆ ನಮ್ಮ ಸ್ಪೀಕರ್ನ ಪರಿಚಯ ಮಾಡುವಂಥದ್ದು. ಆ ಸ್ಪೀಕರ್ ನಿಜವಾಗ್ಲೂ ತುಂಬಾ ಕೆಲಸ ಮಾಡಿದವರು. ಅಷ್ಟೊಂದು ಕೆಲಸ ಮಾಡಿದವ್ರನ್ನ ನಾನು ಹೇಳೋದಕ್ಕೆ ಸ್ವಲ್ಪ ಟೈಮ್ ತಗೊಳ್ತೀನಿ. ನಂಬರ್ 1 ಈಸ್ ಹೀಸ್ PNSM ಪ್ರಿವೆಂಟಿವ್ ಹೆಲ್ತ್ ಅದನ್ನ ಮಾಡ್ಕೊಂಡಿರೋದು. ಅದರಲ್ಲಿ ನಾವು ಒಂದೊಂದು ಪೇಷಂಟ್ನ ನಾವು ಕ್ಲಿನಿಕಲ್ ಕುತ್ಕೊಂಡು ನೋಡ್ತೀವಿ, ಆದರೆ ಅವ್ರದ್ದು ಟ್ಯೂನು ಲಕ್ಷ ಜನಗಳನ್ನ ನೋಡ್ತಾ ಇರ್ತಾರೆ. ಯಾವ್ದಾದ್ರು ಒಂದು ಇಮ್ಯುನೈಸೇಷನ್ ಡ್ರೈವ್ ಅಂತಂದ್ರೆ 1.7 ಮಿಲಿಯನ್ಸ್ ಆ ಥರ ನಂಬರ್ನ ನಾವು ನಮ್ಮ ಕ್ಲಿನಿಕಲ್ ಕೂಡ ನೋಡೋಕ್ಕಾಗಲ್ಲ. ಹಿ ಹ್ಯಾಸ್ ರೀಚ್ಡ್ ದಟ್ ಮಿಲಿಯನ್ ಪೇಷಂಟ್ಸ್, ಟಚ್ ದರ್ ಹಾರ್ಟ್. ಅಂಡ್ ಕೋವಿಡ್ ಅಲ್ಲಂತೂ ಕೊನೆಯ ಗಳಿಗೆನಲ್ಲಿ 1.7 ಮಿಲಿಯನ್ಸ್ ಅವರ ಕಡೆಯಿಂದ ಅವರ ಒಂದು ಡ್ರೈವ್ ಇಂದ ತಗೊಂಡಿದ್ದಾರೆ. ಈ ತರ ತುಂಬಾ ದೊಡ್ಡ ಕೆಲಸಗಳನ್ನ ಮಾಡೋದಕ್ಕೆ ಅವರ ಒಂದು ಪೊಸಿಷನ್ ಹೆಲ್ಪ್ ಆಗಿದೆ. ಇದಕ್ಕೆ ನಾನು ಅವ್ರನ್ನ ಇವಾಗ ನಮ್ಮ ಕೇಸ್ಗೆ ನಮ್ಮನ್ನ ಗೈಡ್ ಮಾಡ್ಲಿಕ್ಕೆ ಬರ್ತಾ ಇದಾರೆ ಅಂದಾಗ ನಂಗೆ ನಿಜವಾಗ್ಲೂ ತುಂಬಾ ಖುಷಿ ಆಗ್ತಾ ಇದೆ. ಟು ಬಿ ಲಿಟಲ್ ಬ್ರೀಫ್, ಅವರ ಬರ್ತ್ಡೇ ಅಂತಂದ್ರೆ May 8 ಅವ್ರ ಬರ್ತ್ಡೇ ಇದೆ. ಈಗ ನನ್ನ ಕಡೆಯಿಂದ ಅವ್ರಿಗೊಂದು ಹಾರ್ಟಿ ವೆರಿ ಗುಡ್ ಬರ್ತ್ಡೇ ವಿಶಸ್ ವೆಲ್ ಇನ್ ಅಡ್ವಾನ್ಸ್, 15 ದಿವಸ ಮುಂಚೆನೆ. ಆದ್ರೂ ಕೂಡ ಮತ್ತೆ ನಮ್ಗೆ ಇದೊಂದು ಪ್ರಿವಿಲೇಜ್ ಅಂತ ಹೇಳಿ ತಿಳ್ಕೊಳ್ತೀನಿ. ಆಲ್ ದ ಬೆಸ್ಟ್ ಅಂಡ್ ದ ಹೋಲ್ ಆಫ್ ಯುವರ್ ಲೈಫ್ ಬಿ ಎ ಗುಡ್ ಡಾಕ್ಟರ್ ಸರ್. ಥ್ಯಾಂಕ್ ಯು. ಅಂಡ್ ಹೀಸ್ ಅವರ ಸ್ಟಡೀಸ್ ಏನಂತ ಹೇಳ್ಬೇಕಂತಂದ್ರೆ ಹಿ ಹಸ್ ಡನ್ ಹಿಸ್ public health condition and public health department in from Sri Chitra to Tirunelveli Institute of Medical Sciences. ಅಲ್ಲಿಂದ MBBS ಫ್ರಮ್ ದ ಗೌರ್ಮೆಂಟ್ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ಮೈಸೂರು, ನಮ್ಮ ಮೈಸೂರು ಕಾಲೇಜಲ್ಲಿ. ಮತ್ತೆ ಹೆಲ್ತ್ ಕೇರ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಎಕ್ಸಿಕ್ಯೂಟಿವ್ ಸರ್ಟಿಫಿಕೇಟ್ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡ್ಕೊಂಡಿರೋದವರು ಹೈದರಾಬಾದಿಂದ 25-26 ಅಲ್ಲಿ. ಇಷ್ಟು ಅವ್ರಿಗೆ ಕೆಲಸದ ಮಧ್ಯ ಮಿಲಿಯನ್ ಕೆಲಸಗಳನ್ನ ನೋಡ್ತಾ, ಮಿಲಿಯನ್ ಪೇಷಂಟ್ನ ನೋಡುವಂಥ ಕೆಲಸಗಳ ಮಧ್ಯ ಈ ಎಲ್ಲ ಕೆಲಸಗಳನ್ನ ಮತ್ತೆ ಡಿಗ್ರಿಯನ್ನ ಮಾಡ್ಕೊಂಡಿರೋದಕ್ಕೆ ಅವರ ತಾಳ್ಮೆ ಎಷ್ಟಿರ್ಬೇಕಂತ ನಾವು ಅರ್ಥ ಮಾಡ್ಕೋಬೇಕು. ಹಾಗಾಗಿ ಅವ್ರಿಗೆ ತುಂಬ ಅದ್ಭುತವಾಗಿರುವಂತಹ ರೆಕಗ್ನಿಷನ್ ಸಿಕ್ಕಿದೆ, ಫೆಲಿಸಿಟೇಷನ್ ಸಿಕ್ಕಿದೆ. ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ಹೆಲ್ತ್ ಆ್ಯಂಡ್ ಫ್ಯಾಮಿಲಿ ವೆಲ್ಫೇರ್ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಕರ್ನಾಟಕ 2013 ರೆಕಗ್ನೈಸ್ ಫಾರ್ ಔಟ್ಸ್ರೀಚಿಂಗ್ ಕಾಂಟ್ರಿಬ್ಯೂಷನ್ ಟು TB ಕಂಟ್ರೋಲ್. ಅದನ್ನ ಅವ್ರಿಗೆ TB ಡೇನಲ್ಲೇ ಕೊಟ್ಟಿದ್ದಾರೆ. March 13th ವಾಸ್ ಅ TB ಡೇ. ಅದೇ ದಿವಸದಲ್ಲಿ ಅವ್ರಿಗೆ ಫೆಲಿಸಿಟೇಷನ್ ಮಾಡಲಾಗಿದೆ. ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಆಫ್ ಹೆಲ್ತ್ ಆ್ಯಂಡ್ ಫ್ಯಾಮಿಲಿ ವೆಲ್ಫೇರ್ ಗೌರ್ಮೆಂಟ್ ಆಫ್ ಮಹಾರಾಷ್ಟ್ರ in year 2021 certification of achievement towards a contribution of project JEET, andre strengthening the private sector also into the mainstream of the service to the public. So ಅದನ್ನ ಅವ್ರದ್ದು ತುಂಬಾ ಇನೋವೇಟಿವ್ ಆಗಿ ಮಾಡಿ, ಯಾವಾಗಲೂ ಪ್ರೈವೇಟ್ ಬೇರೆ ಗೌರ್ಮೆಂಟ್ ಬೇರೆ ಅಂತ ತುಂಬಾ ಬೇರೆ ಬೇರೆ ಆಗಿರೋದನ್ನ ವಿತ್ ದ ಇನ್ನೋವೇಟಿವ್ ಚಾನ್ಸಸ್ ಹಿ ಹಸ್ ಡನ್ ವೆರಿ ಮಚ್ ವರ್ಕ್ ಟು ಇನ್ವಾಲ್ವ್ ದ ಪ್ರೈವೇಟ್ ಪೀಪಲ್ ಆಲ್ಸೋ ಇನ್ ಟು ದ ಗೌರ್ಮೆಂಟ್ ಸ್ಕೀಮ್ಸ್. Then our USAID JSI State Health Department 23-24, he has acknowledged the leadership in COVID-19 vaccination and urban RI strengthening. ಸೊ ಇವನ್ನ ಒಬ್ಬ ಸಣ್ಣ ವ್ಯಕ್ತಿನ ಏನೋ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ, ತುಂಬಾ ಜಾಸ್ತಿ ಶಕ್ತಿ ಇರೋರು ಮಾತ್ರ, ಒಂದು ಡಿಟರ್ಮಿನೇಷನ್ ಇರೋರು ಮಾತ್ರ ಮಾಡ್ಲಿಕ್ಕೆ ಸಾಧ್ಯ ಅಂತ ನಾನು ಹೇಳ್ತೀನಿ. ಎಸ್ಪೆಷಲಿ ಹಿಸ್ ವರ್ಕ್ ಇನ್ TB ಅದರಲ್ಲಿ AI ಹ್ಯಾಸ್ ಬೀನ್ ಆಲ್ರೆಡಿ ಇನ್ವಾಲ್ವ್ಡ್. ಅಂದ್ರೆ ಏನಾಗುತ್ತೆ, ನಾವು ಏನು ಇಲ್ದಂಗೆ ಸುಮ್ಮನೆ ಕೂತ್ಕೊಂಡಿರ್ತೀವಿ, ಬಟ್ ಎಲ್ಲರನ್ನೂ ಒಟ್ಟುಗೂಡಿಸ್ಬೇಕಾದಾಗ, ಒಂದು ಡಯಾಗ್ನೋಸಿಸ್ ಮಾಡಬೇಕಾದಾಗ TB ಅನ್ನೋದು ಅಷ್ಟೊಂದು ಡಿಲೇ ಆಗ್ತಾ ಇರುವಾಗ ಹಿ ಹಸ್ ಇನ್ವಾಲ್ವ್ಡ್ ದಟ್ AI ಬಂದಿರೋದ್ರಿಂದ TB CB NAT ಅದರಿರ್ಬೋದು ಅಥವಾ ಕ್ವಿಕ್ ಡಯಾಗ್ನೋಸಿಸ್ ಇರ್ಬೋದು, ಇದೆಲ್ಲವನ್ನು ಅವರು ಆ ಒಂದು ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಅಲ್ಲಿ ಮಾಡ್ತಾ ಹೋಗಿದ್ದಾರೆ. ಮೇ ಬಿ ಬಿಕಾಸ್ ಆಫ್ ಹಿಸ್ ಎಜುಕೇಶನ್ ಫ್ರಮ್ ಬೋತ್ ಮೆಡಿಕಲ್ ಆ್ಯಂಡ್ ಟೆಕ್ನಾಲಜಿಕಲ್ ಯೂನಿವರ್ಸಿಟಿ ಜೊತೆಯಲ್ಲಿದ್ದಾಗ ಎರಡನ್ನೂ ಅವರು ಇಂಬೈಬ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ ಅನ್ಸುತ್ತೆ. ಸೊ ಹಿ ಹಸ್ ವರ್ಕ್ಡ್ ಎಕ್ಸ್ಟೆನ್ಸಿವ್ಲಿ ಫಾರ್ TB. ಈಗ ಕರ್ನಾಟಕದಲ್ಲಿ NTB ಅಥವಾ ನಿಕ್ಷಯ್ ಅನ್ನೋದಲ್ಲಿ ಅವರ ತುಂಬ ದೊಡ್ಡ ಗುರುತರವಾದ ಪಾತ್ರ ಇದೆ. ಫ್ರಮ್ 26 January he is involved into the HPV vaccination drive which is going on in Karnataka, that especially in Bangalore. He is outreaching ಇಷ್ಟೊಂದು ಮಾಡ್ತಾ ಇರೋದು, ಇಷ್ಟೊಂದು ಜನಕ್ಕೆ ತಲುಪ್ತಾ ಇರೋದು ಅವರ ಒಂದು ಕಾರ್ಯಕ್ಷಮತೆ ಮತ್ತು ಅವರ ಒಂದು ಬ್ರೈನ್ ಚೈಲ್ಡ್ ಆಗಿರುವಂತಹ ಒಂದು ಈ ಒಂದು ಕೆಲಸಗಳಿಂದ ಅಂತ ಹೇಳ್ತೀನಿ. ಇನ್ನು ಅವರ ಚಿತ್ರ 4 ಪುಟಗಳಷ್ಟಿದೆ, ಆದರೆ ನಾನು ಇಲ್ಲಿಗೆ ನಿಲ್ಲಿಸ್ತೀನಿ, ಅವರನ್ನು ಕ್ಷಮೆ ಕೇಳಿಕೊಂಡು. ಬಿಕಾಸ್ ನಿಮ್ಮ ಹತ್ರ ಕೇಳೋವಂಥ ವಿಷಯ ತುಂಬ ಇದೆ ಸರ್. ಸೊ ಇದೊಂದ್ಸಲ ಸಮಯ ಸಿಕ್ಕಲಿ ನಾನು ನಿಜವಾಗ್ಲೂ ನಿಮ್ಮನ್ನು ಎಲ್ಲರಿಗೂ ಪೂರ್ತಿಯಾಗಿ ಇಂಟ್ರೊಡ್ಯೂಸ್ ಮಾಡಲಿಕ್ಕೆ ನಾನು ರೆಡಿ ಇದ್ದೀನಿ. ಧನ್ಯವಾದಗಳು. ದಯವಿಟ್ಟು ನಿಮಗೆ ಸ್ಟೇಜ್ ಪ್ಲಸ್ ನಮಗೆ ಎಲ್ಲ ಅನುಮಾನಗಳನ್ನ ಪರಿಹಾರ ಮಾಡ್ತೀರಿ ಅಂತ ತಿಳ್ಕೊಂಡಿದ್ದೀನಿ. ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಎವ್ರಿ ಒನ್ ಫಾರ್ ದ ಅಪಾರ್ಚುನಿಟಿ.
Thank you. So I now request the speaker to take over.
ಥ್ಯಾಂಕ್ ಯು ಮೇಡಮ್. ಇಂದ್ರ ಮೇಡಮ್ ಅವರಿಗೆ ಹುಟ್ಟುಹಬ್ಬದ ಐ ಥಿಂಕ್ ಈ ಹುಟ್ಟುಹಬ್ಬದ ವಿಷಸ್ ಫಸ್ಟ್ ನೀವೇ ಹೇಳ್ತಾ ಇರುವಂತದ್ದು. ಥ್ಯಾಂಕ್ ಯು ಸೋ ಮಚ್. ಸೊ ಐ ಥಿಂಕ್ ಐ ಆಮ್ ಹಿಯರ್ ಟು ಲರ್ನ್ ಎ ಲಾಟ್ ಫ್ರಮ್ ಯು ಆಲ್ ಆಕ್ಚುಲಿ. ಎನಿ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಪ್ರೋಗ್ರಾಮ್, basically we have to cater to large, as you said, large section of the community. In Indian context, you know that 60 to 70% of the patient, they seek healthcare from the private sector, alwa? Right from the first contact. You see the cascade of services. It start from private practitioner at the grassroots level. Allinda, I mean, secondary, tertiary, ಯಾವುದೇ ಇರ್ಬೋದು. ಸೊ ಯಾವುದೇ ನ್ಯಾಷನಲ್ ಹೆಲ್ತ್ ಪ್ರೋಗ್ರಾಮ್ ನಾವು ಯಶಸ್ವಿಯಾಗಿ ಮಾಡ್ಬೇಕಂತ ಹೇಳಿದ್ರೆ, ಸೊ ಪ್ರೈವೇಟ್ ಸೆಕ್ಟರ್ದು ಸಹಭಾಗಿತ್ವ ಅಂತ ಹೇಳುವಂಥದ್ದು ಬಹಳ ಇಂಪಾರ್ಟೆಂಟು. ಸೊ ಬೆಳಿಗ್ಗೆ ಅನುರಾಧ ಮೇಡಮ್ನವರು ಆಕ್ಚುಲಿ ನಾವು ಡಿಸ್ಕಸ್ ಮಾಡ್ತಾ ಇದ್ವಿ, ಅಂದ್ರೆ ಹೇಗೆ ವಿ ಹ್ಯಾವ್ ಟು make the presentation concise and relevant to the audience, alwa? The content can be of different facets. I mean, we should address to the audience we are talking to. So ad ಮಾಡ್ತಾ ಇರಬೇಕಾದ್ರೆ we are talking about private sector, especially TB ನಲ್ಲಿ, like once upon a time it was just 0.1%, I can say even 0.01% notification from the private sector TB. So to make any planning successful, you need to have the appropriate disease burden, I mean accurate disease burden in the country or a given geography. So private sector in nam bandilla andre. If you are depending on the public sector only, then you have underestimated data. So AML, the country has taken that private sector drive in a large scale actually. So we learned a lot. I had the opportunity to work at the national level to lead one of the biggest project, like joint efforts for elimination of TB. That is the JEET. So basically it's a Government of India initiative. So otherly we have, I mean, seamlessly engaged with the various branches of IMA across the country, multiple states. And we had an opportunity to interact with them. We learned a lot actually. In fact, we learned a lot, like what was the shortcomings, I mean, within the government sector, while engaging the private sector. So many of them shared the insight, where was the gap and what are the new strategies you have to adapt to. I mean, what type of relationship strategies you have to do. So I still remember, like 3 R's you have to manage, while you engage with the private sector. Retention, I mean, revenue and relationship. So I think leaving apart, I mean, let me thank first of all actually this IMA branch giving me this opportunity. Anuradha madam, ಆಮೇಲೆ ವೀರಭದ್ರೆ ಸರ್ ಇರ್ಬೋದು, ಆಮೇಲೆ ಸೂರ್ಯರಾಜ್ ಸರ್ ಇರ್ಬೋದು, ಎಲ್ರಿಗೂ, and Indra madam as well. ಹಾಗೆ ನಮ್ಮ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ ಸೈಡ್ ಇಂದ I thank actually mission director Avinash sir ಇರ್ಬೋದು, Rajni madam project director ಇರ್ಬೋದು, ಈಗ Dr. Chandramohan state immunization officer. I think they only introduced me to you all. So I just recall, thank them. So let us start with, basic thing. Please, feel free to ask questions because I'm not the authority. Many of you have worked extensively. I think I learned from Anuradha madam. They have been working. I just heard, 30,000 vaccinations they are already done when there was no supply within the government. So that's a tremendous achievement. So I think let's take, momentum from that point. What learnings they have got and what we can learn, and while scaling up to. I think I have shared one slide, madam. If if it
Yes,
can be
Karnataka.
included as a last but one maybe, or before 2 slides,
Yes.
I can show you we have a lot of supply of vaccines, but still we have today I think we have reached around 1.55 lakhs. So I mean it's good, but we have to go a long way. I mean, just to consume all the doses before May, we have to consume all the doses, because these children will not get the benefit after May, because they will cross 15 years. So that's the trick. The system will not take. The vaccine is, I'll show you that the single age cohort. So that's the trick we have to, we all have to contribute. So in my small presentation, I think I've taken almost 5 minutes in introduction. Let me cover, let's not worry on that, and we can have a good discussion at the end of the presentation. So I'll start with a little bit on the epidemiology, then the cervical cancer status at the global and Indian level, and the introduction, how in different phases it was introduced at the global level, and how it, where we stand in terms of status of introduction. Then let's go on to the operational guidelines released in February 2026. Based on that, the current strategy is working upon. Then what plans we have at the state and the national level, and subsequently district, and what are the 2 platforms, the online platforms, UWIN and UWIN. You all must have heard CoWIN, right, for COVID vaccination. So UWIN is there for all immunization, even to the HPV also. And there is a stock management online portal, that's eWIN. Then finally, very, very important, the crux of today's presentation is intersectoral coordination. So it's a multi-sectoral coordination program. So without other partners, we cannot go ahead. So where is the role of these medical professional bodies? We really need to think, and which areas in the program we can contribute. So then maybe just on one slide on FAQs, just a title. I think those FAQs are there with madam. She will definitely share, and later on we can conclude with some take-home messages. Yeah, next slide, please. Yeah, this is the national launch which has happened 28th February. All of you know that Honorable Prime Minister has, did the national launch in Ajmer,
Previous
Rajasthan.
slide, John.
Yeah, that's okay. I think, yeah. So state also followed on the same day. We had a state launch. Our mission director has initiated the vaccination. So on the same day, March 1st onwards, all districts have subsequently started simultaneously vaccination for the the eligible beneficiaries. Next slide, please. So I'll not go into the details of cervical cancer. Only one bottom line message is only the persistent infection by the high risk types of HPV virus of the genital tract only will cause the cervical cancer. Otherwise remaining all asymptomatic and resolves spontaneously. All of you are very thorough about 90, 70, 90 global strategy. I don't have to talk more on that, but only my emphasis is we have to achieve 90% coverage before the age of 15. Unless we achieve 80%, we can't achieve the herd effect to protect those unvaccinated children. It's going to be there, whatever level of achievement we do. Then comes 70% screening. That's the secondary prevention and the tertiary care of the existing, females who are affected with cervical cancer. Yeah, next slide. I think, yeah. Okay, so suppose what happens if we don't take a robust prevention and control strategies. I think by 2035, the projected estimation is around 8 lakh new cases as incident cases, and of which 4.5 lakhs deaths are going to happen. So, I mean, though it is projected, not an accurate estimation, but still we can, by HPV vaccination, by adopting primary prevention, we can avert lots and lots of, cases which are going to die due to cervical cancer. Next slide. Yeah, we discussed this. Next slide, please. Is it on a PowerPoint mode? Can we take it on a PowerPoint mode? If it is not, yeah. In India, in 2022, we had reported around close to 80,000 cases and estimated close to 35,000 deaths due to cervical cancer. I think still it is a big number, and I think Suri Raju sir was telling like we have a lot of opportunity to avert these deaths due to cervical cancer. Next slide, please. Yeah. So again, I'll not go into detail about this. HPV, though it has 200 serotypes, only 70 are high risk. Even among 70 HPV high risk, only 2, 16 and 18 serotypes contributes 83% of the cervical cancer in India. So there is one comparison we need to look at. The global level, the attributable fraction for the cervical cancer from 16 and 18 is 77%. In India, it is 83%, which means even if you use a vaccine quadrivalent, we have a better chance response with the quadrivalent vaccine than the global experience, because we are able to handle much of the cervical cancer which are happening due to 16 and 18. Okay, right. Next slide. Yeah. So this slide makes one of the foundational concept for our operational strategy for HPV vaccination in India. I mean, February 2026, which is released. See, among 194 UN member countries, 159 has already implemented before us. See, we are the 160th country. That is something, alarming point. We are already late, so we have to ramp up the activity very fast. And second point is, how many countries have used single dose? 87 countries. Significant chunk of countries are using single dose. So we have adequate data to say that why we are using single dose. And third is, 30 countries are already using facility-based vaccination. Not school-based, not hybrid model, only facility-based vaccination. So that also gives a rationale why within our strategy we are encouraging for only health facility-based vaccination. And the last point is it's a female-centric. So 70 plus countries are doing vaccination only for young females. I mean, 14 years age girls. So thereby they are actually addressing the primary beneficiaries of this, because we have to address cervical cancer, we have to prevent cervical cancer. That's why our aim is to vaccinate young girls who are at the age of 9 to 14. But in India, we are currently we have taken up single age cohort, that is 15 years completed but not yet completed 15 years. We will discuss later. Next slide, please. Yeah, so I'll not go detail again. We have around 8 vaccines across the globe and 4 vaccines which are available in the country, and we are using Gardasil 4 only. Okay, only Survivac, which is produced by Serum Institute of India, still the immunobridging study is ongoing. We don't have the complete data with regard to efficacy and immunogenicity for the single dose schedule. Otherwise, Cervarix, Gardasil 4, Gardasil 9, each of these have the data for the single dose usage. But Survivac, we are still waiting. Once it comes, probably our domestic indigenous vaccine will be available for the country's vaccination purpose. Next slide. Yeah, this is the document. I have shared the link, madam, for your reference and to circulate. This is the operation guideline document released in February 26. It has tremendous information. I mean, a lot of information about the rationale, evidence, and strategies, why we are using a particular strategy, why we have not adopted, particular strategy, all the evidences which are available across the globe, it is available. So kindly utilize for various, workshops, seminars, etc. Next slide, please. Yeah, let's look at the nitty-gritties of our current strategy for the HPV vaccination campaign. So as far as the vaccine is concerned, we are using quadrivalent Gardasil, which is freeze sensitive. It should be stored between 2 to 8 degrees. So that's why whenever you use a vaccine carrier, the ice packs has to be conditioned so that it should not be below 2 degrees centigrade. It should be stored in ice-linked refrigerators. Even in the private sector, we should ensure that this is stored between 2 to 8 degrees. And it is a least heat sensitive. VVM 30 means vaccine vial monitor indicator 30. So let's not go into detail that it's a least heat sensitive. Oral polio vaccine is VVM 2, which is highly heat sensitive. I'm just giving a contrast example. And it is a single dose schedule, liquid vaccine, so 0.5 ml given intramuscularly on the left upper arm in the deltoid region. So which is the platform we use? Currently, we use only government health facilities, primary health center, community health center, or any government hospital, even the government medical colleges also. Why we are using that? Because we have to ensure that trained HR, human resources, storage should be good, and safety monitoring. So within government health facility, we have a very robust control. So that's why the country has decided we will do it from the government health facility. The campaign is for 3 months, started from March till May, and at the May end, it will be ended. But we don't know, Government of India might take a decision to continue, considering the school vacation and all those things. Probably they may continue, but as of now it ends at May, so we have to hurry up to utilize the remaining vaccines. Target population, as I told, girl aged 14 years but not yet celebrated 15th year birthday. It's a single age cohort, because a lot of beneficiaries are coming 12, 13, 16 and 17. So as a practitioner, as a medical fraternity, we should know the actual the eligibility criteria for the vaccination. So please remember that at each health facility, government health facility, we are ensuring that 4 people are there in the vaccination team to do remaining deliverables like vaccination, verification of the documents, entry in the UIN portal, and crowd management. So this is well managed vaccination campaign, so the people can come with confidence and get the vaccination comfortably. Next slide, please. Yeah, so another important point is it's a non-live virus. So virus-like particles from the outer shell of the virus is used for vaccine preparation. There is no genetic material involved in the vaccine. So there is no possibility of infection post-vaccination. I think this is one thing we have to be very, very clear, the nature of the HPV vaccine. What are the criteria to exclude any particular type of beneficiary? Number 1, pregnancy, which is a rare, but pregnancy is excluded. Second, if anybody out of this age cohort, 12 year, 13th year, or 16, 17, we don't give the vaccine, though they can get the vaccine, but we don't give within the program. Third, if somebody at this point of time is sick, we want to defer to the next date when they get better. And fourth point is any previously vaccinated, very, very important. If they are vaccinated in any sector, government or private sector, they don't have to take the vaccine again. Or if they have taken only 1 dose out of 2 dose regimen, we don't give, because we believe in single dose, that is, adequate enough to give optimum immunogenicity as well as, adequate duration of protection. So no need for, repetition of the vaccination during the campaign or subsequent integration into the routine immunization program. So I think these exclusion criteria are very important. I hope all of you have gone through these, quickly gone through these points. We have jotted it down. As I told earlier, it is given on the left arm for the uniformity purpose, and also it's a non-dominant arm. And another one important point is, when you get an opportunity or a situation where you have to give multiple vaccines like measles, rubella, or it may be JE vaccine, then you have to, follow the rules of, when you give multi-vaccines, what are the guidelines you have to follow? You have to follow, which means you can give along with the vaccines like MR and JE. There is no exclusion for this condition. So if somebody comes from outside state, we have to vaccine in the campaign. So there is no geographical barrier. People can take any states or any districts in this country. So we cannot restrict from getting vaccinated. And there will be a finger marking option. Left index finger will be marked after the vaccination. That is for the monitoring purpose. And the last point is very important point is, they should not go on empty stomach. That may lead to some syncopal attack, may lead to a misconception of, linking it to the adverse effects of the vaccination. Next slide. Yeah. So this is one very, very cardinal aspect of the vaccination, why we have moved from multi-dose regimen to single dose schedule. Multiple studies from Kenya, I'll show you the next slide, shown that single dose vaccine has shown a stable level of antibody titer, immune response, even up to 10 years. Even post that period also, there are proof of concept studies which are adequately shown that it has adequate immunogenicity it has produced by the single dose when you compare with the 2 and 3 dose regimens. Okay, so peak antibody titer happens 4 weeks after the last dose, and it is the effectiveness is almost close to 93 to 100% in preventing cervical cancer. And one more important point is, the vaccination response, serological response, is much stronger than the response after natural infection, because the antibody titer produced by the natural infection is very slow and it takes a longer duration. So that is not as effective. It's not effective to mitigate the risk of developing into cervical cancer. Next. Yeah, these are the few evidences. So I will drop all these full text articles. One study from Kenya, and from Tanzania, India, and Costa Rica. All these have consistently said, single dose regimen is as effective as multi-dose regimens. Next slide. Next slide, please. Yeah, this is just a nutshell. You might have, you may, suppose if you are not, grasp some points we discussed, just what are the key cardinal points about the campaign. That vaccine used is Gardasil. It's a quadrivalent. It is, the serotypes included in the vaccine are 6, 11, which is to non-high risk serotypes to prevent, genital warts, and 16 and 18 are high risk oncogenic serotypes. The only manufacturer for this brand is Merck, and this is WHO pre-qualified in 2009. 0.5 ml dose intramuscular route in the left upper arm. I hope I'm clear about these points. Next slide. Yeah. So I will not, because this is a public health concept, but why, you might be asking why I'm talking to you all about the planning, because at least this will give some light on, throw a light on, the robustness in terms of planning, and robustness in terms of rolling out plan, implementation plan. So all those things will help you get a bird view actually about the whole campaign and the program. Next slide, please. Yeah, national and state and districts have different laws, right from macro planning to micro planning. Next slide. Yeah, national level, mostly they are involved in, compiling or collating the evidences available across the globe through NTAGI, National Technical Advisory Group for Immunization. They will adopt certain policies, like what best works for India in terms of cost benefit, cost effectiveness. Like in a country like India, when resources are constrained, we cannot adopt some strategies which Western countries are adopting. I hope you all agree with me. So we have to see each rupee spent, how many cervical cancer we can avert. That kind of analysis will happen at the top level. Based on that, they will adopt the guidelines, policies, the operational strategies, all those things. And they have also developed UWIN, the online portals for the vaccination. See, please remember, vaccination registration, vaccination details, everything happens only through the UWIN portal. And the stock management of all vaccines happen through the EVIN, that is Effective Vaccine Intelligence Network. So these are the cardinal tools which we use for stock management as well as the monitoring or the documentation of the recording and reporting of the vaccination. Next slide. At the state level, it will guide the districts in terms of training, target estimation, helping them to mobilize the resources in terms of HR, logistics, supply of vaccines, training, and identification of the adverse events following immunization centers, like which are all the centers can be eligible for AEFIs. So those kind of overall hand-holding, little bit of translating these policies into the implementation strategies, these kind of things are done by the state level. Next slide please. So at the district level, still focus happens. We boil down to sort of implementation components, like for example, actual estimation or enumeration of the HR at each health facility level, how much vaccines are required, and the funds and the session site planning and training, cascading training for each cadre of the staffs, and the micro planning formats, and how do they conduct the headcount survey. Accurate estimation of the beneficiaries are important, because these are very, very costly vaccines. All of you know that if you don't accurately estimate, somebody might be oversupplied with the vaccine without understanding the logistic maintenance. They may waste the vaccines, or somebody bigger districts like Bangalore and Belgaum and all may be undersupplied. Many beneficiaries miss out the things, because once they cross 15 they may not get the vaccine. I think these are all the some nitty-gritties or the planning nuances we need to take care of. Next slide please. Yeah, finally, some key messages which is in addition to whatever we have discussed in the previous slides. Apart from single dose, waiting, observation for 30 minutes post-vaccine is something very important. I'll tell you, from the social point of view also, if somebody goes out in the field after vaccination, they collapses, by fainting, not due to the vaccine, that may be attributed to the vaccine. Somebody captures the video, and lot of video circulation and misconceptions are being spread in the community. So that may become a hindrance for the vaccination campaign. Another point is AEFIs. So far 159 countries, 50 crore doses since the licensure of the vaccine in the year 2006. There are no reports of major AEFIs, except very, very few instances of anaphylaxis, which was properly dealt or managed. So even in Karnataka, 1.5 lakhs doses are given. I have not heard of any major AEFIs. So let us be very, very, not overconfident. Let us be confident with all precautions taken care that this is very safe vaccine, highly efficacious, and should be given without any delay, without giving any scope for communication gap. And vaccination certificate, something new which was not there. We are giving certificate taken from the UWIN after vaccination, so that the child can carry the vaccination certificate as a proof for the HPV vaccination. Next slide. Last couple of slides. The first one is UWIN platform for vaccine stock management. Second one is, the middle one is certificate. Third is UWIN. I request all of you to try this link, UWIN portal. Citizen can self-register. They can schedule an appointment with the nearby health facility, the day and the time which they prefer. Actually, that option is there. Suppose if they are not so literate or didn't get a time, they can straight away walk into a nearby health facility. There the staff will do the registration. Somebody go without registration, we are not going to stop them. We are going to register and give the vaccination. Suppose internet is not there, they will take a written consent signed, and further, once the internet comes, they will upload the vaccination details and the consent form. Yeah, next slide. Yeah, so before that, one more addition here. Consent is brought in here as per the Digital Personal Protection, what you call Digital Personal Data Protection Act 2023, which says that anytime you take these confidential patient data, even with the minors, you have to take the consent. So consent in terms of explaining the benefits and risks, then the informed decision should come for the vaccination. So since they are minors, the parents' presence is must. If not parent, guardian should be there, but parent should be able to share the OTP. That is for the digital consent. Yeah. So I think we'll move to next slide. Then we'll come back to the only last two slides. Next slide, please. Yeah. So we have a FAQs on various subtopics. I have shared with Madam. She will be sharing with all of you. I mean, starting from basic, from the, what is cervical cancer and, HPV infection, global strategy. I mean, last 3-4 points are special situations. What you will do if somebody is previously vaccinated, and some of the evidences for, giving you the confidence in terms of safety and what are the contraindications, dose, schedule, efficacy. All these things are later part of the FAQs. These are, I think, very important. So I request all of you to go through in your free time. Let's go to the previous slide, which we want all of you to give attention. Yeah, this is the one slide I request. I mean, one of the reason I wanted to spend some time with you all is, see, intersectoral coordination. As I told you, education department, women child department, urban what we call urban local bodies or Panchayat Raj institutions, then backward, what we call minority department. So various departments, they coordinate with us, we coordinate with them, so that whatever they can contribute, on an official note, they coordinate at the district level and they support us. Similarly, another component is medical colleges. So we are, interacting with medical colleges to, take up some of the monitoring aspects and also, serving as a tertiary center for treating the AFIs. Coming to medical professional bodies, IMA, IAP, or FOXI, they have a tremendous role. As I mentioned, some of the only few points I like to jolt it down. One is communication, active involvement in the campaign. There are various ways you can do that. One is some of the IEC materials in relation to the misconceptions and the facts I shared again, and those can be actually publicized or disseminated through your individual or maybe IMA association social media handles, so that is visible and accessible to wider community. That is one way. And second thing is advocacy efforts. You being trendsetters and opinion leaders, you can participate in various seminars and workshops and talk about why HPV vaccination is very, very important in preventing cervical cancers. You can use your professional networks or maybe sometimes, public platforms. You can create awareness campaigns. Couple of additional points are, ensuring your members are updated with accurate information. This is one effort I'm seeing. Many of you are getting the information what is incorporated in the current Government of India vaccination program. So this has to be terminated. It should be, transmitted or disseminated to propagated to all the members of the IMA across the state and across the country. So how we can make it possible? So they have a right, because I have seen interacted many people, they need to get updated some of the things. It's not wrong. I mean, they don't have a wrong information, but some of the things can be updated. So how do we reach out to them to communicate the accurate information? And what are the strategies we can adopt as a private practitioner, as a IMA member in addressing misinformation? Maybe, is it possible to engage with the media? Can you all address, some of these things through the public sensitization workshops. And some of the eminent practitioners, they are very active in, LinkedIn, profiles, or, other, various social media platforms. They are very active. Why can't they disseminate, some of this information so that people are aware? Because through WhatsApp, you get to know a lot of videos. Anybody can create a video. They can actually transmit wrong information because political reasons, or very biased reasons. So when eminent doctors disseminate right information, people will listen to them. So that is the best way of combating the misinformation which is happening across any vaccination newly comes into the program. And adverse events, suppose if you come across any adverse events, feel free to report. Even one case among 100 practitioners is also very important to undertake the causality assessment. So whether these events are because of the vaccine, or is it a coincidental factor? That's very important. So we have a state AEFI committee at the state. So we are closely monitoring what is happening in the field. I think this is the last slide, probably. Next slide is there. Yeah. I think, I hope I could finish and it might have taken maybe a couple of minutes extra.
John, can you display that last slide, what sir has requested?
I'm doing.
Yeah. Dr. Fatima has a question. Is there any contraindication, especially in case of 1 minute? Especially in immunocompromised state, thanks to IMA for all its cooperation. Contraindication in case of immunocompromised state.
Yeah, as per the operational guidelines and also WHO position paper, there is no contraindication. It should be given. Suppose immunocompromised, or anybody on immunosuppressants, they should be given vaccination, but not the single dose, preferably 2 doses, and if possible 3 doses.
So what we have been following is even those girls and boys less than 15 years, recommendation though was 2 doses. These immunocompromised girls and boys needs to be given 3 doses. And
Yes.
you also
Yeah.
told the same thing. Thank you.
Yes.
Dr. Ramohan, you have a question. Is it girls aged 15 years vaccination? After 15 years, sir?
Yeah, so just I'll give the broader picture. WHO position, because deliberately we have not kept the WHO position paper, because a lot of comprehensive information. Now we have a very focused approach. So they say 9 to 14 is a primary prevention, and they don't. Vaccination should be done before the active sexual life starts. So once they are exposed to HPV strains, what happens? The HPV vaccination effectiveness comes down, because that won't work to the person when vaccinated. Particular strain, if it is there in the infected person, it won't work against that strain, serotype. So after 14, once somebody completes 15 years, there is no recommendation as a primary strategy. It can go till 25 also. 50, we categorize them as 15 to 16 to 20 and 21 to 25. So up to 20 now the single dose is recommended. Up to 20.
So, sir, your suggestion for us private practitioners is, suppose we are, one challenge that you were mentioning, that you private doctors may have a challenge because we are giving it free of cost. Sir, you are covering only 14 to 15 year age girls. So we still have 14 to 15 years boys, and the rest of the men and women to be vaccinated. So I don't think we private practitioners should bother about this. In fact, we all should encourage all the 14-year girls to take the free vaccination. So now, what was I asking? I forgot. Indra, ಏನು ಹೇಳ್ತಾ ಇದ್ದೆ ನಾನು ಮರ್ತೋಯ್ತು.
So whether to, what about, other age group?
Yes, sir. So
And-
now, when we get, of course, less than 15 years for all girls and boys, we will give single dose because government is already doing the same thing. But if after 15 years, up to 20 years, you still recommend one dose. So after 20 years, if someone comes,
Yeah, 2 dose can be given.
6 months interval.
Yes.
And for men, Gardasil research says that it is it's effective only up to 26 years old men and boys. So for men, we stick to 26 years, up to 26 years.
Yeah, 25 years, because as they become older, the efficacy, I mean, the effectiveness comes down. So, I mean, it's ideally should be given 9 to 14 as a primary targets. The older men and, MSMs or boys, even 9 to 14, all are secondary targets. Because if you are able to cover 80% of the eligible population, that is the girls basically, you develop a herd effect, and that will protect the unvaccinated secondary targets. So in that case, you don't have to vaccinate the boys and the older females if you are able to achieve 80%.
So, sir, the take-home message that I get from this particular webinar by you is, make sure that you don't leave even a single girl unvaccinated. So we have to see to it that each and every girl that you and me come across, rich and poor, we don't have any discrimination. For those who are less than 14 years, we'll have to compromise and make sure that we give the vaccination either through sponsorship or by the patient paying. But 14-year girls, none of us should leave even one single girl unvaccinated, because government has taken that bold step. That is a message that I've taken. So I think wherever I go, my eyes will go only towards girls, and to find out what the age they belong to. Thank you, sir.
Sir, I have a question,
Dr.
sir.
Deepak.
Hello.
Yes, sir. Yeah.
I have a question. So, putting this one dose, how much protection will be there, sir? Percentage, like for 100, how much 100% protection?
Yeah, they say 93 to 100%. I mean, that's the range, you can say. And the studies, in the study settings where I think 3,000 plus participants have, involved in Kenyan study, it has rendered around 97.6%. Or especially for the serotype 16 and 18. But when, because I didn't use some of the information, because that might, create some
be negative
conflicting information. For example, Gardasil 9, it has a wider confidence interval starting from 68.1 to 92.3, something like that. So, I mean, can I say that Gardasil 9 is not that effective? So, I mean, the interpretations are different actually. So, because they are using additional 5 serotypes, 31, 33, 45, and 52, and 58. So, I think let us not go into that. So, I think Gardasil 4 is covering, 16 and 18, which is, 83% attributable fraction for the cervical cancer.
Okay, sir. Thank you. Thank you so much.
Dr. Deepak, I have a question.
Yeah, madam. May I know
I am Dr. Geraldine. I am in
madam.
forensic medicine.
Yes,
and I'm deeply concerned about these campaigns that we are having in pushing the vaccines onto our people, particularly minor children. And I don't know how many studies have been done on the long-term effects of these vaccines. If you're targeting girls, that to target itself is a word, it's not the patient health. You're not really considering the individual child and the family, where the sexual, development is concerned. And just targeting them and giving a vaccine, is it going to prevent them from having sex, sort of thinking that, okay, I've taken this vaccine, therefore I can have sex with whomever I want, and how many studies have been done on the long-term effects of these vaccines? And as you know, in Kenya, actually, Bill Gates was pushing this vaccine campaign, and he was really banned from that country, even in India, because of the tribal girls who had died. And as you said, it's a campaign, it's a controlling thing, it's not the health of the individual.
Okay. So I'll give you one example, madam. I mean, our ability to generalize the things. So let's take a simple example. 100 people, smoked and 100 people did not smoke. So you will see among non-smokers also still somebody will get cancer. So can we say, see, he has not smoked, but still he got a cancer? Or among 100 smokers, 5%, I mean, I'm telling 5 or 10%, whatever maybe, did not get cancer. Can we say that, see, you see him is still alive till 90? Those are all, outliers, cannot be generalizable. What is that proportion get the, expected outcome? Is it significantly different? I mean, statistical way, if you think. So if one instance has happened in one corner of the country or a world, has anybody done the causality assessment? What is the source of, what is the validity of the, the source of the information, how valid it is? Has anyone interrogated, investigated? Has they arrived that this has happened?
Yeah, yes, Dr. Deepak, that's why at the international, courts, these vaccine manufacturers are being held accountable, Pfizer and so on, AstraZeneca. The World Economic Forum and Bill Gates has said very clearly, to decrease the population, we have to have proper vaccine campaigns. It's not just the attenuated virus or whatever. It's the adjuvants and so on which cause infertility, inflammation. Okay. And, considering the health of our children, I'm really, quite this about what's happening.
Madam, with due respect to your whatever the thing you are sharing here, we can debate on and on. You can continue to pose the questions. I can argue and give scientific facts and all. So I don't have any such kind of thing. These are all rumors. These are all rumors among few which are already running. So I don't attribute any scientific validity, I mean scientific rigor to such kind of informations which are flooding around the corner actually. So if you still want to do that, I request you to share the documents which you are talking about through madam. I will respond accordingly, which can be shared with all the participants here. That way we can do that.
Yeah, Dr. Deepak.
Yeah.
Very, very insightful and very beautiful presentation. Government has been given targets now to vaccinate numbers, anything like that?
Yeah. So,
right.
Yeah. Sir, I think, I will add one more, the queries people are asking, the target and all those things. See, target is something like a goal. You are in an ocean and you need a destiny to sail through, right? If you don't have a destiny, you'll be wandering around. This is not your question, but I'm just taking this question to answer this. So targets we have given, what is our magnitude? What is the quantum of beneficiaries we have to, and what is the timeline we have, so that we understand at what speed, what scale we need to vaccinate our beneficiaries, what level of efforts in terms of IEC activities, in terms of coordination with the various sectors, in terms of mobilization of resources. For that purpose we need. Yeah, coming to your this thing, Karnataka, that's a very good question, sir. 1% of the population, as per the previous census data estimation for each age group, that says 1% of the population is this single age cohort, that is 14 years completed, and those not yet completed the 15 years. As per that data, Karnataka has around 6.89 lakh, the beneficiaries are eligible for this campaign and, in coming routine immunization days. But we have been supplied with 5 lakh, around 8,000 doses. We have consumed till now around 1 lakh 55 doses. So we have around left with the 3.5 lakh doses. So in 1.5 months, we have to do that. So since it is a campaign, everyday vaccinations are happening. Per health facility, it will become 10 to 12 vaccinations per day. When you break down to a particular health facility level, which is quite achievable. Because of the vacation and the exams, it took a little, slow phase. I hope I answered, sir, your question.
Thank you, sir. Thank you. And right now, it's the free vaccine is available. Again, how we can associate, IMA can associate with government and help in the vaccination program, sir.
Yeah. So a couple of things I mentioned when I was talking about in the last slide. One is like, you can conduct workshops for the private doctors to give them the right information, what government of India or the state is doing to such a 5 lakh doses, we never had across the country. Actually, one state is having now. How we will bring that awareness to the community level, how we can mobilize those parents who are parents of those beneficiaries, and how do we communicate the right information for the miscreants, those who are spreading misinformation, using the social media handles, disseminating the IEC material. Some of the materials I have shared with madam also. You can be the trend sector by posting those materials in your handles, social media handles, so that you will have many followers. As being a doctor, they will understand what is myth and what is facts. So people will adhere to the vaccination program, and more people will come. Word of mouth will help the villagers actually mobilizing those innocent women who are mothers of those children, so that people will be deprived of some kind of these kind of for sure preventable measures which we are giving for cervical cancer. They will not be deprived because of the lack of communication, wrong communication, inaccurate information.
Sir, we have two extremes here. We have the affording affluent class who will think that this is not for them. And we will have the poor people who have not been adequately informed. So these two groups we have to target, because whatever information that we are now spreading with respect to you in your own health center, be it a hospital or a clinic, and with respect to you at your health centers, apart from that, I feel these two we have to target. And as our secretary asked, you will also have to give us some suggestions as to how to mobilize them.
Yeah. So I think you have answered it very aptly in the beginning itself. Whatever the way, however, whichever platform, whether public or private, our aim is to reach those beneficiaries, right, with the vaccine. So whether it government sponsored or it is private from the private, it doesn't matter. Why country is introducing is, our country is a developing country, resource constrained country. Much of the populations are non-affordable, and the vaccine is very costly. So it's a sort of market failure. In economic language, we have a word called market failure, and government intervenes. So this is one area where government has to intervene, because much of the population cannot get the vaccine because of the affordability issue. So affluent class, definitely, if they get the right information in a right time, they will get the vaccine even from the private sector also. They are welcome to government sector also, that they can get vaccinated. This is open for all, both public, private, affluent and poor, all gradient of the socio-economic spectrum, they have accessibility. But now the question is your low socio-economic or maybe slum dwellers. So here again, how do we penetrate with the right information to build the confidence, address their vaccine hesitancy or the resistance they have, and mobilize them to the nearest facility? See what happens, the challenges are, it's a multi-pronged, like multi-dimensional, I would say. So for example, you have a vaccine nearby within a kilometer, they have got the right information, but they don't have a time, because the moment they take their children on that day, they will have to forgo their daily wages. They earn every day and they take care of their day-to-day expenses. They don't have any savings. One day they lose means next day is going to be pathetic. So that's the kind of situation a lot of poor people are leading their life. So these are the barriers. So how do we address that? Can we conduct a vaccination site in the odd hours, maybe in the late evening, when they come back home, they can bring their children to the vaccination. Can you do it in the weekends? The middle class workers who cannot get the leaves, can they come and get their children vaccinated on Saturdays or Sundays? So these are the extra miles we have to run from the public sector to reach out to those people, not physically inaccessible areas, but because of the certain living conditions brings the barriers. As I, just now I give the example. For the affluent class, only right information it has to be reached. They can access both public and private sector. There is, government doesn't say that private sector should not vaccinate. We encourage private sector to vaccinate. It's, I mean, as far as the fee and all considered, government doesn't have any issues. But the only thing is right dose, right intervals, and the right vaccine should be given at an appropriate age. That's very important.
Sir, I think quite a lot of others would want to ask questions.
And the storage conditions.
So I wouldn't want to intrude into others' time also. One sincere request from us private doctors to you is, why don't you get some, what to say, star matinee person or anybody for that matter. Some of our doctor friends said don't want politicians because people will not listen properly. So my suggestion is, if you can get somebody to propagate that we are running on a campaign on TV, I think it'll be FM. It has started. I can one or two I did hear, but on the TV channel, I feel we need a celebrity.
Okay.
And for herd immunity, definitely we need the affluent society also. In my personal experience, touching these affluent people also is a big challenge. Of course, my senior gynecologists tell me that you will have to touch the slum people, slum dwellers. There, the hygiene is bad, and so there we are going to miss out on cervical cancer. So you better focus only on them. Yes, you are focusing, and we will also come to your rescue. We will also volunteer to do some sort of activity. Of course, in our IMA meeting next Sunday, we will take up the topic and see, we'll work out on some strategy. But coming to the affluent class, I've noticed that the very stubborn, no, they can afford, but they refuse to cooperate. They don't. A small group. A celebratory, sir, from your side.
We will try, madam, because now we are little bit handed in the sense, the scale and the speed which is happening, and the our own internal resources, and government works a lot, working a lot on multiple programs, and people may complain about government on various things. I'm not talking about many things, but I'm talking about at least health system. I'm working with them. We are part of that. See, they are working day and all the officers. I think Veerbhadra sir is also deputy director and at the state health department. They start their day by 8 o'clock and they go back around 8, 9 every day. And multiple tasks they do, because they are covering such a huge population, and challenges are huge. So I think we will try to do, madam, coming back to your point, we will try to do, but right now, immediately I can assure you, but once we get some time and some resources within our own, government funding, we'll try to do that. So, if somebody from the IMA side, we are happy to coordinate and give some support in terms of technical aspects. That is also most welcome.
Good. I think any other questions? ಹೇಳಿ ಮೇಡಮ್, ಇಂದಿರಾ ಅವರು ಕ್ಯಾಂಪ್ ಅಲ್ಲಂತೂ ತುಂಬಾ ಸಿಕ್ಕಾಬಟ್ಟೆ ಆಕ್ಟಿವಿಟಿ ಮಾಡ್ತಾ ಇದ್ದಾರೆ, ಪರ್ಟಿಕ್ಯುಲರ್ಲಿ ಫಾರ್ ಗವರ್ಮೆಂಟ್ ಸ್ಕೂಲ್ಸ್ ಇನ್ ಅರೌಂಡ್ ದೊಡ್ಡಬಳ್ಳಾಪುರ್. Certainly we would like to listen to you.
Yes, ma'am. Thank you for your kind words. Sir, ನಂದು ಒಂದು ಪ್ರಶ್ನೆ ಅಂದ್ರೆ, ಮೇ ದಟ್ ಕನ್ಫೈನ್ಮೆಂಟ್ ಇಸ್ ಬ್ಯಾಡ್ because we can catch the 14 years girl, majority of them in the schools. So in government school start ಆಗ್ಬೇಕಂದ್ರೆ June 1st ಆಗ್ಬಿಡತ್ತೆ. So this May will be ಸ್ವಲ್ಪ little constraint ಅನ್ಸುತ್ತೆ. ಸ್ವಲ್ಪ if you can extend up to May 5th, at least June 15th ಅಂತನಾರು, that can be completely covering the 14 years age. And one more thing is, ಆಸ್ ಯು ಸೆಡ್ ಸಂಡೇಸ್ ಅಥವಾ ಔಟ್ ನೈಟ್, ಇವಾಗ ನಮಗೆ ನಮ್ಮ ಕ್ಲಿನಿಕಲ್ಲ ಇವಾಗ ಸ್ವಲ್ಪ ಬೇರೆ ಕಡೆ ನಡೀತಾ ಇದೆ, ಲೇಟಾಗಿ ನಡೀತಾ ಇದೆ, ಅಪ್ ಟು 7 o'clock 7:80 8 o'clock ತನಕ ದೇ ಆರ್ ಗಿವಿಂಗ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಟು ದ ಪೇಷಂಟ್ಸ್, ದೋಸ್ ಆರ್ ಗೋಯಿಂಗ್ ಫಾರ್ ದ ಜಾಬ್ ಅಂಡ್ ಆಲ್. ಸೊ ಇದನ್ನು ಅಲ್ಲಿ ಮಾಡುವಾಗ ಒಂದು, ಡಾಕ್ಟರ್ ಅನುರಾಧ ಸೆಡ್, ಒನ್ ಸೆಲೆಬ್ರಿಟಿ ಲೈಕ್ ಹೌ ಅಮಿತಾಬ್ ಬಚ್ಚನ್ ಕೇಮ್ ಫಾರ್ ದ ಟೂ ಬೂಂದ್ ಅಂತ ಹೆಂಗಾಯ್ತು ಅವಾಗ. ಸೊ ಇದನ್ನ ಒಂದು ಮಾಡಬಹುದು, ನಂಬರ್ 1. ನಂಬರ್ 2, IMA ಕಡೆಯಿಂದ ನಾವು ಎಷ್ಟು ಹೆಲ್ಪ್ ಮಾಡಕ್ ಸಾಧ್ಯನೋ ಮ್ಯಾಕ್ಸಿಮಮ್ ವಿ ಡೂ ದಟ್. ಅಂಡ್ ಥರ್ಡ್ ಒನ್ ಈಸ್ ಸ್ವಲ್ಪ ನಾವು ಇವಾಗ ಅಲ್ಲಿ ಲೋಕಲಿ ನಾವು ಏನಾದ್ರು ಮಾಡ್ಬೇಕಾದ್ರೂ ಲೋಕಲ್ ಪ್ರೆಸಿಡೆಂಟ್ ಇರ್ಬೋದು, ಲೋಕಲ್ ಲೀಡರ್ ಇರ್ಬೋದು, ಅಥವಾ ಯಾರಿಗಾದ್ರೂ ಒಬ್ಬರಿಗೆ ನಾವು ಬನ್ನಿ ನೀವು ನಿಂತ್ಕೊಳ್ಳಿ ಇಲ್ಲಿ ಮಾಡಿ ಅಂತ ಹೇಳಿದಾಗ ಅವ್ರ ಕಡೆಯಿಂದ ಹೋಗ್ಬೇಕು. ಒಂದು ಬರ್ತ್ಡೇ ಅಂದ್ರೆ ಇಷ್ಟು ಖರ್ಚು ಮಾಡ್ತಾರೆ, ಒಂದ್ ದಿವಸ ನೀವು ಇದನ್ನು ಕ್ಯಾಂಪೈನ್ ಮಾಡಿ, ಒಂದ್ ದಿವಸ ನೀವು ಇದನ್ನ ಬಂದ್ ಮಾಡಿ, ದಿಸ್ ಇಸ್ ಫಾರ್ ದ ಪಬ್ಲಿಕ್ ಹೆಲ್ತ್ ಬರುತ್ತೆ ಅಂತ ಹೇಳಿ ಯಾರಿಗಾರು ಒಬ್ಬರಿಗೆ, ದೋಸ್ ಆರ್ ಆಲ್ ಇನ್ವಾಲ್ವ್ಡ್, ರಿಚ್ ಪೀಪಲ್ ಆಲ್ಸೋ, ಪೂರ್ ಪೀಪಲ್ ಆಲ್ಸೋ, ಎಲ್ಲರಿಗೂ ಅವ್ರು ಕೇಟರ್ ಮಾಡಬಹುದು. ಇದೆರಡು. ಮತ್ತೆ ಮೂರನೇದು, ಸ್ಕೂಲ್ನಾಗೆ ನಮಗೆ ವಿ ಹ್ಯಾವ್ ಆಲ್ ದ ಇನ್ಫಾರ್ಮೇಶನ್ ಆಫ್ 14 years ಗರ್ಲ್ಸ್ ಇನ್ ದ ಸ್ಕೂಲ್ಸ್. ಸೊ ಅವ್ರನ್ನ ನಾವು ತಗೊಳ್ಲೇಬಹುದು. ವೆನ್ ಐ ವೆಂಟ್ ಫಾರ್ ಸ್ಕೂಲ್ ಇಮ್ಯುನೈಸೇಷನ್ ಪ್ರೋಗ್ರಾಮ್ ಅಂಡ್ ಆಲ್, ತುಂಬಾ ಸಲ ನಾವು ಮಾಡ್ಬೇಕು ಸರ್. ಅವ್ರಿಗೆ ಕೇಳಲಿಲ್ಲ, some 10 cities we did, 1, 2, 3 ಅಂತ. So it is a long process. May is a little constrained. At least extend another 15 days, sir. When the students come back to the school, we can just really catch hold of them. Already they are aware. ಇನ್ನೊಂದು ಸ್ವಲ್ಪ ನಾವು ಮಾಡ್ಬೋದು. 15 ತನಕನಾದ್ರು ಟೈಮ್ ಕೊಡಬೇಕು, ನಂಬರ್ 1. ನಂಬರ್ 2 ಈಸ್ ವಿ ಆರ್ ಆಲ್ ದೇರ್ ಟು ಗೋ ವಿತ್ ದ ಹೆಲ್ಪ್. ಅಂಡ್ ಯಾವ್ದಾರು ಒಂದು ಕಮ್ಯುನಿಟಿ ತಗೊಳ್ಬೇಕಾದ್ರೆ ವಿ ಕ್ಯಾನ್ ಟೇಕ್ ದ ಹೆಲ್ಪ್ ಆಫ್ ದ ಗೌರ್ಮೆಂಟ್ ಪೀಪಲ್. ಜಸ್ಟ್ ಲೈಕ್ ಇವಾಗ TT ತಗೊಂಡು ಹೋಗ್ತಾರೆ, ಇನ್ನೊಂದು ತಗೊಂಡು ಹೋಗ್ತಾರೆ, ಸ್ಕೂಲಿಗೆ ತಗೊಂಡು ಹೋಗಿ ಇಂಜೆಕ್ಷನ್ ಕೊಡ್ತಾರೆ, ಆ ಥರ ಅಟ್ ದ ಸ್ಕೂಲ್ ಲೆವೆಲ್ ಮಾಡಿಕೊಂಡ್ರೆ ತುಂಬಾ ಕೆಲಸ ಆಗುತ್ತೆ ಸರ್. ಬಟ್ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಎಕ್ಸ್ಟೆಂಡ್ ಅಪ್ ಟು 15th ಅಟ್ ಲೀಸ್ಟ್. ಯಾಕಂದ್ರೆ ನಮ್ಮ ಸ್ಟೂಡೆಂಟ್ಸ್ ಬರೋದೇ ಕಷ್ಟ, June 1st ಗೌರ್ಮೆಂಟ್ ಸ್ಕೂಲಿಗೆ ಬರ್ತಾರೆ. ಸೊ ದಟ್ಸ್ ಒನ್ ಥಿಂಗ್. ಅಂಡ್ ಪ್ರೈವೇಟ್ ಸ್ಕೂಲ್ ಎನಿವೇ ಅವ್ರ ಫೀಸು ಮತ್ತೆ ಇನ್ನೊಂದು ಕಲೆಕ್ಟ್ ಮಾಡುವಾಗ ಬನ್ನಿ ಹಾಕಿಸ್ಕೊಳ್ಳಿ, ಇಟ್ಸ್ ಮ್ಯಾಂಡೇಟರಿ ಅಂದ್ರೆ ಖಂಡಿತ ಆಗತ್ತೆ ಸರ್.
No, it is not mandatory. There should be informed consent. 14 years means minors,
Yes,
and no celebrities, particularly film actresses. As it is, the films are pushing, vulgarity and pornography in Tavella. So I don't think you should get a celebrity. It should be a parent, or a stakeholder, women who have undergone, who have developed cervical cancer, sex workers, whoever who are prone to having cervical cancer. That would be because we're talking about health. We are not targeting these children, catching them and giving them something which is destructive. It is health. We're talking about health. Thank you.
Yeah, I think thank you, Geraldine madam. Madam Indra, I think definitely we will, state is also planning to send a request to Government of India to extend few days. Probably we may achieve that one. But one sensitive point ಏನಿದೆ ಅಂತ ಹೇಳಿದ್ರೆ, ನಾವು ಎಷ್ಟೇ ದಿವಸ ಕ್ಯಾಂಪ್ ಎಕ್ಸ್ಟೆಂಡ್ ಆಗ್ಬೋದು, ಬಟ್ somebody who reaches 15, whether campaign is there or on a routine immunization days it happens, after 3 months also it will continue madam. ಎವ್ರಿ ಥರ್ಸ್ಡೇ ಆಗುತ್ತೆ. ಬಟ್ ಏನಂದ್ರೆ 15 ವರ್ಷ ಆದ್ರೆ ಅವ್ರಿಗೆ ಆಗೋದಿಲ್ಲ. ಕ್ಯಾಂಪೇನ್ ಅಂತ ಯಾಕೆ ಹೇಳೋದಂದ್ರೆ, ನಾವೀಗ 15 ವರ್ಷ ಇನ್ನೂ ತುಂಬಿಲ್ಲ ಅಂತ ಮಕ್ಳಿಗೆ ಕೊಡೋದಕ್ಕೆ ಬಲ್ಕ್ ಇಟ್ಕೊಂಡಿದೀವಿ. ದೇ ಆರ್ ಸ್ಟಾಕ್ ಪೈಲ್ಡ್. ದರ್ ಇಸ್ ಅ ಹ್ಯೂಜ್ ಪಾಪ್ಯುಲೇಷನ್ ದೇರ್. ಸೊ ನಾವು ಪುಷ್ ಮಾಡೋ ಟಾರ್ಗೆಟ್ ಒಂದೇ ಅಲ್ಲ, ಆ ಮಕ್ಳಿಗೆ ರೀಚ್ ಆಗಿ ಕೊಟ್ಬಿಡೋಣ ಅಂತ ಮಾಡ್ತಾ ಇರುವಂತ. ದಟ್ ಈಸ್ ಅವ್ರ ಈ ಕ್ಯಾಂಪೇನ್ ಆದ್ರೂ ಆ ಮಕ್ಳು 15 ವರ್ಷ ಆದ್ರೆ ಅವ್ರಿಗೆ ಸಿಗಲ್ಲ ಅಂದ್ರೆ. ಬಟ್ ಏನಾಗುತ್ತೆ ಅಂದ್ರೆ 15 ವರ್ಷ ಆಗದಿದ್ದವ್ರಿಗೆ ಸಿಗುತ್ತೆ. ಯುವರ್ ಪಾಯಿಂಟ್ ಈಸ್ ಆಲ್ಸೋ ವ್ಯಾಲಿಡ್. ಮಾಡಿದ್ರೆ ಎವ್ರಿ ಡೇ ಅವ್ರಿಗೆ ವ್ಯಾಕ್ಸಿನೇಷನ್ ಫೆಸಿಲಿಟೀಸ್ ಸಿಗುತ್ತೆ ಅಂತ, ಡೆಫಿನೆಟ್ಲಿ ಇಟ್ ವಿಲ್ ಹೆಲ್ಪ್. ಬಟ್ those are on the edge towards the 15 years, if they complete 15 years they will not be eligible ಅಷ್ಟೇ. But this point is valid. The major chunk which is towards this side, 14 3/4 complete ಆದವರಿಗೆ probably that will be beneficial if we extend by 15 days or 1 month.
This one.
So with permission of the audience, it's already 10 o'clock. I think with a very huge, big thank you to our speaker for sparing time. Extremely busy schedule, but still he made sure that he consolidated his big presentation into such a small presentation, and we all did benefit from you. We have had lot of take home messages, and we look forward to listening to you if possible, and if all our friends are interested for another IMA webinar session, because he has another group of frequently asked questions slides. They are really very good, and if everyone wants, probably we'll plan it for the next webinar for the next month. Thank you, sir. And I request our membership drive committee member, Dr. Raju, with his busy schedule, is patiently waiting to give us vote of thanks. Thank you, sir. Dr. Raju.
Thank you, madam. As we conclude today's session, I'd like to extend a sincere thanks to IMA KSB President, Dr. Veerbhadra sir, IMA KSB Secretary, Dr. Suraraju sir, IMA KSB President-elect, Dr. Harish Delantabadu sir, and special thanks to our today's webinar speaker, Dr. Deepak KG sir, for your valuable and detailed inputs regarding HP vaccine. And thanks to our second speaker and chairman of our membership subcommittee, Dr. Anuradha Parmesh madam. And thanks all the IMA members for active participation. Thank you one and all. Good night, Shubharatri.
Thank you. Thank you all. Thank you.
Thank you. Thank you.
Thank you and good night.
Thank you. Thank you, ma'am.
Good night.
Thank you, sir.